Testing 1, 2. Good morning. Good morning. Good morning. Good morning. Good morning. I've been told to get up here and start the day because I'm stopping and having a lot of conversations because I love being here with all of you and seeing you. And so I just wanted to come up this morning and I wanted to say good morning. And I hope you all had a restful evening and were comfortable at the hotel and had a nice breakfast. We have a great program. This is our one full day of the conference. We are going to go until 11:30 this morning, just to tell you what's on docket today. At 11:30, we'll go to lunch, and there will be a extended break until 12:45. And then we will wrap up the day today around 3:30, and there will be a block of time before we have the dinner tonight, which is our themed dinner tonight, which is a themed pirate dinner. So look forward to that. That's going to be a lot of fun. We have a lot of fun things planned for that. Okay, so now, without any further delay, I would like to introduce our Vice President of Global Marketing Communications, Michael Antonellis. He's going to introduce our first speaker of the day.
Good morning, everyone. Thank you. I'm really honored to do this first introduction, but I did want to let everyone know that we have a couple of hundred people watching this event live cast virtually as well. So if everyone could, wave and yell and welcome those folks who are watching. Thank you so much. I'd like to introduce Dr. Sri Muppidi. Dr. Muppidi is a neurologist in Palo Alto, California, and affiliated with Stanford Healthcare and Stanford Hospital. He received his medical degree from Osmania Medical College. Sri specializes in neuromuscular diseases, including, of course, myasthenia gravis. He is the co-leader of the Stanford Support Group, which meets every month via Zoom. Dr. Muppidi volunteers for so many different MGFA events and programs, including webinars, blogs. He writes educational material, and he's also a part of our Medical and Scientific Advisory Council. Please welcome Dr. Sri Muppidi.
Thank you, Michael. I hope you all can hear me at the back there. I usually have to adjust my mic when I come up. So for those of you who I haven't had a chance to meet, I've met some familiar faces, folks who flew in from Bay Area. I'm one of the neurologists at Stanford, along with a couple more of us. We see a lot of patients with myasthenia. And apart from taking care of the patients that I personally see, patient advocacy has been a sort of interest of mine. And as Michael said, I've had a chance to dedicate a lot of the times, weekends, some of the evenings with, I think I see her back there, Jessica back up there. Basically, Jessica says, Sri, do this, and I do this. And so that's how it works. But it's been a joy. And it's incredible to see this organization grow as the way it has grown. And a lot of the credit goes to folks, again, at the back there, Dover and Co. for pulling these off. It's amazing, the audience that I see. So we'll talk a little bit about MG antibodies and what do they mean to you. I've given a version of this talk locally at our institute and in the Bay Area. This thought came up to me and I proposed it to Dover, I think about a year ago, because as you will see and you'll hear, a lot of the therapies, there has been an incredible development of therapies in the myasthenia field, are specific for certain antibodies. And naturally, I assumed all my patients knew what their antibodies were. That's the way I thought they would. It's in their notes and I talk about it. Of course they know. And then one of my patients, when one of the newer drugs got approved, reached out to me and said, oh, I heard that there's this new drug, but they said it's for this antibody. Do I have the antibody? And that was sort of an enlightening experience for me. It's like, oh, I obviously was assuming too much. At the same time, when I gave this talk to a regional group, there were questions that could have been asked in a scientific forum without an answer. And so trying to find a balance between where I can involve everybody, but then it doesn't look too boring or too simple. So I hope I'll meet that. So we'll talk a little bit about MG antibodies. What do they mean? Why you should know your MG antibodies. I had proposed to Dover at some point that there should be a Know Your Antibody Day, just so that you take a minute to ask yourself, what is your antibody? Anyways, so those are my disclosures, nothing really relevant to this presentation. So some of the objectives of the talk. Again, a lot of these, many of you know, I suspect, but just so that we can make sure we're all on the same page. We'll talk a little bit about what is an autoantibody. How do specific antibodies cause myasthenia gravis? And why do you need to know your antibody? That's the most important thing, because maybe 15 years ago, probably wouldn't have mattered too much, because you could have said, my doctor knows my disease. He has few drugs that are available. They can recommend these drugs. But now, as the way the field is going, some of the drugs are FDA approved for certain antibody status. And how we approach the disease, how aggressively we treat it, what's the first line drug that we use for a particular disease is likely dependent on the antibody. And so maybe we can go back a couple more steps back. And before we get to the antibody, what is an autoimmune disease? Autoimmune disease is a disease where your body is attacking you for any particular reason. It can involve any number of organs, all the way from skin to brain to lung, liver, so on and so forth. In myasthenia gravis, it attacks where the nerve is connected to the muscle, where the signal from the nerve goes to the muscle. Usually, we don't quite know why a person gets autoimmune disease when they get. Sometimes there are certain clues. Maybe they had an infection and this got precipitated after that, but usually we don't know. We suspect there's more than one element as to why one gets an autoimmune disease. There could be some potential genetic predisposition that they might be at risk to get an autoimmune disease. They've always had that risk, but they don't always have the disease. There might be some environmental factors that kind of precipitated or pushed it to the border, pushed it to the edge. Sometimes there could be sort of a dietary changes that have happened over a period of time, and it took a while to sort of change your microbiome, which is the gut flora, and then the autoimmune disease comes to the surface. But we don't exactly know when that happens. Certain diseases which are precipitated by infection or surgeries, we might say, well, that might be the precipitating cause. It might not be the only cause. The reason I bring this up is that, at least in my practice, this happens. I'm sure others might have heard this too. Usually I see the patient with the spouse, and the spouse likes to say, well, he or she did this. I told them not to do it, but they wouldn't listen. They did this, and it happened. I try not to get myself into it, but most of us should listen to our spouses all the time, and things would be much better. But it's never that simple. But there are multiple different factors as to why you get an autoimmune disease. Beyond why you get when or why you get an autoimmune disease, there is sort of a progression to an autoimmune disease. So just because you develop myasthenia, let's say if I get myasthenia tomorrow, or I get symptoms of myasthenia starting tomorrow, I probably had some evidence of it before I developed the symptoms. I probably had the antibodies, but something that sort of pushed it over the edge where my symptoms have come up. And we don't quite know always what those precipitating factors are. We don't obviously go around testing everybody for everything under the sun. We cannot possibly do that. And the more important thing is that if you had the antibody, but if you don't have the disease, what do you do about it? This happens, especially in myasthenia. Sometimes patients are incidentally found to have a mass in their chest. They get that surgery taken care of. Sometimes they check their antibodies and they have the antibodies. And so you know it's a thymic problem. It gets taken care of, but they have no overt myasthenic symptoms. It happens maybe every 4 or 5 months or so in my practice. We don't currently actually treat them with any of the drugs because there is no marker to assess what we are trying to treat. So they likely had the disease, and if we were to just watch them, maybe the disease will manifest itself in future. That happens sometimes. And the other important thing is that while we don't know exact progression in every individual, sometimes after we treat, the disease does change. We don't always know exactly how it changes after we treat patients either. With that in mind, we'll go through some more information regarding what an immune system is. So immune system is there to fight against infections predominantly or anything that's foreign. Most of you flew in. I flew in yesterday. I'm going to fly back tonight. Hopefully, none of us will get sick after these long flights. The reason we won't get sick is because our immune system will fight against anything that we are exposed during the flight, during crowded spaces. Sometimes, and so that's if you're exposed to something right then and there, there's a fast immune system that can fight against it. There's also a slow sort of adaptive immune system, which recognizes that you were exposed to that particular virus or at the last flight maybe, and you developed antibodies. And so when you're exposed to it again, it fights against that. So you don't get sick. And that's great. That's what it's supposed to do. And it's an impressive system. And within that adaptive system, there are 2 different mechanisms. There is a T cell mechanism or a cell-based mechanism, and there's a humoral-based mechanism. And what you need to know, basically understand about this is that the humoral-based mechanism is where the antibodies are produced, and the cell-based mechanism is a direct cell response to whatever the body is exposed to. And the body has an intrinsic way of figuring out what it's exposed to, isolating it, so that your body can recognize that particular trigger and attack it. And this is where the antibody comes into picture, because these antibodies are there to fight against the infection. You might have seen it, lots of posters now with these Y-shaped structures that an antibody has. And so it has 2 different regions, the antigen binding site, the FAB, and the FC region. The FC region is critical for sort of the recycling part of the antibody, and the 2 sort of the heads of the Ys recognize whatever it is that it's supposed to attack or supposed to attach itself and fight against. And so those are the important parts of an IgG antibody. There are many Ig antibodies. We typically care about the IgG antibody, which is the simple Y, but there are other antibodies that sort of do different functions. There are some in your mucosa, in your sinuses that fight certain infections, so on and so forth. They all have different half-life, which is how long they are in your system before new ones need to be produced. But the critical one for us is these antibodies, IgG antibodies, because these are the ones that when they are produced and then they are attacking your cells, that's an autoantibody. In myasthenia, these are the relevant antibodies that we need to be thinking about. And why does an autoantibody come up? This is a challenge. We have a sense of why it might come up in certain situations, but we don't always know why it comes in. For example, if let's say you had an infection before, some kind of trigger that made you produce the antibodies, because when you had an infection or trigger, your body produces a response to it. Somewhere along, there is sort of mimicry where the trigger response, instead of attacking whatever it is, the pathogen or the foreign substance, also starts attacking different parts of your own body. So that's one way. There are other sort of elements where your body loses the threshold to recognize that, oh, something is my own body part, not a foreign substance. And sometimes that's also produced as a part of, you might have heard about, some of you might have heard about these new chemotherapy drugs called immune therapies, where essentially the drugs prevent your body from recognizing cancer as own, and then attack it. But when you take away that break in the immune system, it can actually precipitate other autoimmune diseases. So that there are many different reasons of that kind which lead to this immune response and production of the antibodies and then disease manifestation. Going back to, we'll talk a little bit about specifically myasthenia and then sort of finish up with why you need to know the antibody. There are many phases to the myasthenia. Many of you have experienced some of these things. The classical ones that patients usually talk about, somebody who has significant weakness in their eyelids, so drooping of the eyes, weakness of their face, not able to smile fully. For example, the man up here has multiple things going on at the same time. So he has weakness of the face, weakness of the eyes, so he's trying to hold it up. But at the same time, there's weakness of the head, and so he's trying to support the head and the eye and have a conversation at the same time. There's certain types of myasthenia called mask myasthenia, where it can be, much more sort of sometimes challenging to diagnose if there was not recognized early, can actually even lead to loss of muscle bulk, such as atrophy of the trunk muscle. Occasionally, you'll also have, let me see if I can play this. Patients might have difficulty with their speech. And as you will hear his speech going forward,
19, 20, 21, 22, 23, 24, 25.
and you could hear that at the beginning when he started 1, 2, 3, it was just completely normal. There was nothing abnormal. As he crossed 15, the threshold where his speech became a little bit more slurred. So sometimes it's beyond weakness, beyond what you're able to observe. There are difficulties, challenges with speech. So if you have this kind of problem, imagine having a conversation. It's extremely difficult. It's very self-conscious. You feel uncomfortable. People might ask you, could you repeat yourself? That makes you feel even more worse because like, oh my gosh. And so I've had many patients who stopped working because they felt uncomfortable in a meeting. People were sort of looking at them, are you all right? And once that comes to the threshold, it becomes a challenge. And so this, I only bring it up because sometimes I'll put this myself in this bucket. We see patients when we see them for a short period of time. Sometimes we see them first thing in the morning in clinic, and they're doing great. We talk to them and speech looks perfectly normal. They go home, they had a full day, and then if I just listen to them at 6 p.m., it's completely different. But we don't always capture it. And so that's an important one for myself to always think of when somebody says, well, my speech is off, it might be off at different points than the point that I'm actually seeing them for. How do we diagnose myasthenia in clinical practice? Again, many of you have sort of gone through this practice, but it's important to make sure we're all on the same page. A lot of the times, the diagnosis only comes up once you clinically suspect it. Once you think, oh, I might have myasthenia, or your healthcare doctor thinks you have myasthenia, things go relatively easily. The biggest first challenge is thinking of the disease. If it presents the most classical way, then I think it's reasonably easy for a doctor to think of it. But if you're a primary care physician, you only probably have like 2 myasthenia patients among 1,000 patients that you take care of. You don't normally always think of it unless that if it comes up, obviously. In clinical practice, you can examine them, you can do strength testing, you can see if the muscles are getting fatigued as you're exercising them. And the most common first antibody that we check for is the AChR antibody. And if that's positive, you have the right clinical picture, then you have myasthenia. If that's negative, you can check for MuSK or LRP4 antibodies. If those are still negative, we do a test called repetitive nerve conduction study. I'll show it to you. Sometimes we do another test called single fiber EMG. If you do all of these panels of things, we recognize myasthenia almost in every one of them. There might be an occasional exception here or there. But sometimes that diagnostic process takes a while because you're getting one test, takes a few weeks to come back. You might have to go and see a different specialist, get another test, so on and so forth. A lot of the times in our practice, at least large university practices, we try to schedule all of these at the same time, or as many of these at the same time as possible, And so that you can sort of cut down the time to diagnosis. And if one of the tests, the antibody comes back positive, you don't need all of the physiology tests that we sometimes do. So those are the different antibodies. Again, many of you will know this, but I want to make sure we're all on the same page. The most common one is the AChR antibody, the acetylcholine receptor antibody. That takes about 80% of the patients or so have that antibody, usually associated with some kind of thymus problem. The second most common one is the muscle-specific kinase. Third one is the LRP4. Sometimes those three antibodies are usually done sort of in multiple different labs. There is also an assay called cell-based assay, which is developed for all the three antibodies. The cell-based assay, and I'll show it to you a little bit about what a cell-based assay in a few minutes, is slightly a bit more technically challenging, only done in few labs. If you don't have the antibody by regular testing, the top three, then you should get a cell-based assay, because that picks up few patients where the antibody levels are so low that unless you let the antibodies capture itself on a cell, live cell, you're not able to pick it up. If those are all negative, we say it's seronegative myasthenia gravis. How do we diagnose myasthenia beyond the antibodies? Usually the antibodies are, diagnostic in most patients. But other ways we diagnose myasthenia by doing this test called repetitive stimulation. Some of you might have had this. Slightly painful. I've had it multiple times myself. Trainees do it on us before they go and do it in practice. And so this is where we isolate a nerve or a muscle. So in this case, you will see these patients getting stimulated on a nerve called ulnar nerve, which is in your hand, and then recording from a muscle in the palm. And so essentially what you're able to see is that each sort of bump that you see is one stimulation. If you were to do this test on me, for example, all the bumps will be of same size because all the bumps have the same amount of electrical signal, and so how much the muscle contraction should be the same. But in patients with myasthenia, you will see as we give more shocks, the height of the bump goes down. That means that there is fatigue and the muscle is not able to contract at the same level. And so you'll see multiple other responses after a brief exercise. Again, the height of the response goes down significantly. That tells you that the problem is at the nerve muscle junction. And what you're seeing is a fatigue of the muscle contraction. This is very similar to the man that counted from 1 to 25. When he was from 1 to 15, speech was almost normal. But then as he kept going, it became slurred because he was using those muscles again and again and again. This is looking at it from a physiological point of view rather than just listening to it. If this is not diagnostic, there's another test called single fiber EMG. Technically a bit more challenging. Not every center might be able to offer this test, but probably the most sensitive of all the tests that we currently do to diagnose myasthenia. Essentially, without sort of boring you with physiology, there is a small needle that is put into the muscle, and it has a very small recording area. And the recording area basically captures two of these very small muscle fibers. And so when you contract your muscle, the muscle fibers are firing. And so we try to see how the two muscle fibers are firing. And this is like in a normal person, for example. In a patient with myasthenia, the muscle fibers don't necessarily fire in unison because the signals are not getting to the muscle fiber exactly the way they should or they would in a normal person. And so we try to capture that and as a way to diagnose the disease. And if you go through those tests, most of the time you capture the disease. But just to make sure we're all on the same page with the different antibodies and how they cause the disease. So this is a normal neuromuscular junction where a signal comes from the nerve down. The little purple dots that you see are the acetylcholine, the chemical that gets released into the neuromuscular junction. It binds to the receptors, the acetylcholine receptors, and that leads to muscle contraction. And so these are the receptors or the wells that take the acetylcholine, leads to muscle contraction in the bottom. There are other receptors called the MuSK or LRP4 that are also critical for us to how these receptors work. And so that's a normal neuromuscular junction, how it works. Obviously, in a normal neuromuscular junction, there is no weakness. In patients with myasthenia gravis, there are different antibodies that can cause the problem. So there are these acetylcholine receptor antibodies, there are MuSK antibodies, LRP4 antibodies. The acetylcholine receptor antibodies, either bind or block the receptors, so the wells are not there, not available to take the acetylcholine. They also do something called activate complement. Complement is a protein that's critical to fight against infections, but it also gets activated if you have an autoimmune response, like an antigen antibody response. And so they also stimulate complement, and the complement gets deposited in that area and causes damage. The antibodies against MuSK and LRP4 work slightly differently. The MuSK LRP4 complex is critical for these AChR receptors to be together, so what we call clustering, so that they're all working together in a small area. When that receptor complex, the MuSK LRP4, is not working well, it prevents these from clustering or being together, and that impairs how well the signal gets transmitted across from nerve to the muscle. There are multiple subgroups to myasthenia. Many of you, there are different ways of classifying how you want to think about the disease. We talked about the different antibody ways of looking at it. So the AChR, the MuSK, LRP4. You can look at it from early onset to late onset. So have you had it in your 60s, 70s, 80s in your life? Or did you have it much younger in life? Is it involving all of your muscles? We call it generalized myasthenia. So, or is it just in your eyes, just ocular myasthenia? Or is it a disease that's associated with thymoma, for example, problems with your thymus gland or a tumor of the thymus gland? Occasionally, patients with myasthenia have other autoimmune diseases, either as a part of the disease, or think of it as sort of a umbrella where somebody is exposed or potentially has a reason to have multiple autoimmune diseases. One of the spokes of that umbrella is myasthenia. When we diagnose patients with myasthenia, we look for certain autoimmune diseases actively, including thyroid disease. Occasionally, it happens that patients had other autoimmune diseases, have had many symptoms, and it took a while for the physician and the patients to recognize there is more to this than my thyroid disease, and I should get checked for other things. The association is important because if you have multiple autoimmune diseases, just treating myasthenia is not going to be sufficient. And so the other ways to classify the disease is by antibody basis, as we talked about before. One of the questions that usually comes up in practice, and one of the questions I want to make sure that we're all on the same page, is the different techniques of testing the antibodies. You don't have to know every details of the technique. We don't run our own lab at Stanford. We send out these samples, so it's not like our lab does it by themselves. There are three main mechanisms that it's usually done. The most common one is this method called radioimmunoprecipitation assay. It's done in a test tube, just like the sample shows. Basically, they take the patient's serum and they look for those antibodies based on whether the antibodies can bind to a receptor, and then they look for a titer where it's able to bind. In most situations, you're able to pick it up. There is another method called ELISA method, again, a similar technique. Take the patient's serum and see if there is able to bind to a receptor in a sample. Less commonly done, ELISA, RIPA is the most commonly done. The challenge is that in some patients, the antibody levels are low enough, or the antibodies are not tightly binding enough that when you do it by RIPA technique, it might look and come back as normal. In those situations, we do a test called a cell-based assay. Cell-based assay is actually a live cell, and then the cell surface has the acetylcholine receptors. And so when you add the patient's serum, it's able to bind, and there is another fluorescent component that's added to it so that you can look at it under a microscope. So even a small level of antibody levels, we call them low affinity. Affinity means how tightly they bind. Even in those situations, patients, even with those small levels of antibodies or low affinity antibodies, you would get a positive test on a cell-based assay. I personally think it should be standard of practice going forward that if you have a routine antibodies that are negative, you should do a cell-based assay. The challenge, of course, what happens in clinical practice is that they have routine antibodies negative, they're getting different immune therapies, and the antibody levels change if you're on active immunotherapy, and you sort of potentially might have lost a window to prove that the cell-based assay would have been positive. And so in our practice, at least we try to do these as soon as we can. If they're negative, we move on to the next step as quickly as possible. I'm hopeful in future, as labs develop and then sort of a standardized technique comes about, is that if the patient has a Reaper-based or ELISA-based negative, they automatically do a cell-based assay without requesting one more sample to be sent. But it is not quite there yet. I'm quite optimistic it'll get there soon enough because it's inefficient in this current system where you send one sample, it's negative, patient has to come back, send another sample to a different lab with different requirements. It's a challenging thing for both practices as well as physicians and patients. How do AChR antibodies cause the disease? I briefly touched upon this, but important to emphasize a few important things here. So there are three main mechanisms that the AChR, the most common form of the antibody, causes the disease. Either it binds or blocks the receptors. And the third one it does is it causes complement activation and deposition of the complement. We have known that the complement activation and deposition occurs in myasthenia for like almost 30, 40 years. But only recently, maybe 7, 8 years now, that we've had complement therapies that prevent this from happening. Usually, a lot of the other fields, we might be able to tell. For example, when I prepare slides like these, and my wife usually looks at them, she's in the tech field, and she usually tells me, oh, at the bottom, when you write these different options, you should always write a percentage beside them, because that way you know how much of it is binding, how much of it is blocking, how much of it is complement activation. Because that's what they do in computer science. They know exact percentage of how things work, and we tackle them the right way. You should just put it there. And then I usually try to say, well, in medicine, we're different. We don't work like that. But she wasn't too impressed with it. But we don't quite know. We don't quite know. And that's a challenge. That's one of the challenges. We don't quite know why in a single patient a certain drug works or a certain drug doesn't work. Partly because we don't know how each part of the antibody causing mechanism causes the disease. Again, I'm optimistic in future it'll change. But a lot of the therapies that we use some of them are really targeted, some of them are not targeted. So for example, we talked about how the AChR antibodies cause the disease binding, blocking, or complement. But some of the traditional therapies that we use, things like azathioprine or Cellcept, prednisone, they basically work higher up. They suppress all kinds of cells in the immune system. And so naturally, when you suppress largest of the immune system, it also sort of increases the risk of certain complications, including infections, because you're suppressing globally. But the advantage is that it will just suppress the degree of antibody being produced. You can also be very specific, like you can do something called plasma exchange, for example. But even in plasma exchange, when we do the plasma exchange, this is where you take a patient's blood, filter it, give it back to them. We take out all of the different kinds of proteins. We just don't take out just the antibodies. And so even though in those situations, you're likely taking out some of the important antibodies to fight against infections that everybody needs to have, because the filtration membrane doesn't quite recognize the subtle differences between them. But you can have, and we are, I think, moving in that direction, you can have very targeted therapies. And I'm hopeful that these will become uniquely available for all patients as we go forward. One of the common ones that you might have heard about, and there are lots of information out there too, are the complement therapies. So these only work this part where the circle is, just prevent the complement from being deposited. It doesn't do anything higher up. It doesn't do anything to the antibody level. And so if you are on a complement therapy, and if you're wondering, well, can I just take a complement drug and be done with it? Why do I have to take 4 different drugs? And this is where it depends upon how your disease is progressing and what the main symptom burden is. Because yes, you can prevent this from happening, but would you want to do more up here? Would you want to reduce the antibody levels? Is there any benefit of doing that on top of the complement one? And so these are some of the challenges as to how do we add different medications so that we can do things higher up and then lower down. And would that have much more of a synergistic benefit? And so that's one of the challenges that you will, as you talk to your physicians, we always sort of try to find a balance. Obviously, we don't want to suppress everything because then the risk of infection, risk of complication goes up. So trying to find a balance for an individual patient. There are few complement therapies that are already FDA approved. And most of you might have seen these slides, but they're basically, these are therapies that are given by injection form currently. The first one is the drug called eculizumab, FDA approved, I think, 2017-ish. In a clinical trial, here, for example, the blue is drug, red is placebo, patients who participate in the clinical trial. And you will see there are different markers. The top left one is called MGADL, myasthenia gravis, activities of daily living. Many of you might have done this survey in your clinical practice. There are many online tools that you can do this. Gets you a sense of how your activities of daily living, your lifestyle is impacted by the disease. And so in a clinical trial, patients were started on the drug or placebo, and you can see there's significant improvement within a few weeks after starting it. Other thing that we have noticed in these trials, we call these Christmas tree patterns, which is how much of what percentage of patients improve by what number. So higher improvement means stronger or more improvement in general. And then you will see blue is eculizumab, red is placebo. Patients who are on eculizumab improve a lot more compared to patient placebo. Similar mechanism for another drug called ravulizumab, which is also a complement inhibitor, but much more longer acting. So eculizumab is generally given every 2 weeks as an intravenous infusion. Ravulizumab is given essentially every 2 months. You will see the same Christmas tree pattern. Here it's purple, which is the drug, red is placebo. So higher levels of improvement. And patients, when they start the drug, have a clear improvement in their symptom burden compared to the drug very quickly after starting the drug, within a few weeks, which is different from traditionally the drugs that we've used. Azathioprine, mycophenolate, these drugs take many months to work. The other drug, the latest one, is called zilucoplan, which is a subcutaneous self-injection. Again, you will see the same Christmas tree pattern, higher level of improvement with drug compared to placebo. And then you will see these graphs within 1 or 2 weeks after starting the therapy, patients have a clear improvement in their overall symptom burden. And so these are some of the complement therapies that are currently approved. I try not to go into the ones that are in development because there's so many of them, and I will definitely miss out for one or the other. The reality of it is that if even the newer upcoming complement therapies, if they prevent that complement deposition, I expect them to work. But they come with newer advantages. There are drugs that are being developed as a tablet form. There are drugs that are being developed as a subcutaneous injection, but less frequently. So it makes it easier and less challenging for patients to take the therapies. What other therapies do we have beyond the complement therapies for the FcRn patients? Beyond the complement therapies, we have FcRn therapies. What do these do? So we talked about this part being complement. How about the antibodies? Can we come up with a strategy as to just reducing the antibodies? And this is where the FcRn therapies come into picture. And this is relevant because we currently have a way, or we used to have a way, still do. We are reducing the antibodies, which is called plasma exchange. We take your blood, filter it, give it back to you. We reduce the immunoglobulin levels. As we reduce all the immunoglobulin levels, the antibody levels reduce too. But if any of you had this procedure or have read about it, it's very labor intensive. You require a catheter. Only few, again, large institutes can offer it. Smaller hospitals might not be able to offer the test on a routine basis unless you are hospitalized. And so there are lots of challenges. But if there is a way where you can achieve this reduction in antibody levels and immunoglobulin levels without doing the procedure, that would be great. And this is where the FcRn drugs come in. We talked earlier about those little Y-shaped structures, the Fc region, the bottom of the Y of the immunoglobulin. And these drugs, so the bottom of the Y binds, and sort of these immunoglobulins get recycled. And so these drugs, the FcRn drugs, essentially prevent the recycling from happening. And so when you prevent something from recycling, then the levels of that particular element, the antibody levels, go down significantly. Of course, it goes down by all the immunoglobulins, all the IgG immunoglobulins, but specifically, you're trying to make sure that the antibody levels go down. And so this is sort of how the immunoglobulins, IgG immunoglobulins get recycled. And this is where these FcRn drugs work by preventing the recycling from happening. And so it's a great way to reduce antibody levels quickly without going through all the procedure of a plasma exchange. There are few drugs that are FDA approved, few drugs in pipeline. They all seem to have fairly similar reduction in your immunoglobulin levels. There are some differences as to how frequently they are given, what is the sort of frequency and cycles and so on and so forth. But they all seem to have reduction in their immunoglobulin level. And so I'm hopeful, because they all have a reduction in immunoglobulin levels, in future, we'll have multiple different options with different scheduling frequency to give you the flexibility of choosing which kind of drug that you would like to take. Again, just going back to some of the data and the relevant data, you will see the Christmas tree pattern. Blue is drug, red is placebo, higher levels of improvement. And then other remarkable thing that you will see, again, looking at the MG-ADL, blue is drug, red is placebo. After starting for the efgartigimod drug, after starting the infusions, within 4 weeks, there's a sort of a dramatic reduction in their MG-ADL, so improvement in their symptoms. If you were to graph it along with their IgG levels or antibody levels, it really replicates how these things happen together. So one nice thing about these drugs is that they're quick acting because they reduce your antibody levels quickly. You should be able to appreciate this kind of response fairly quickly after 1 or 2 cycles of the treatment. So efgartigimod is FDA approved. There is an IV form, there is a subcutaneous form, and the other drug, rozanolixizumab, is the other drug that's also FDA approved for AChR positive as well as MuSK-MG. Again, you will see sort of a clear improvement in symptom scores soon after starting across the board, but multiple different ways of assessing symptoms like all of the other clinical trials. So these are a couple of the promising FC therapies that are already approved, but there are a few more in the pipeline being developed, and I'm optimistic there'll be more choices for patients going forward. But what about MuSK-MG? So a lot of the things that I talked about are AChR positive MG. How does MuSK work? We talked a little bit about it at the beginning. The LRP4 MuSK complex is critical for the clustering for the AChR receptors to be together. So if there's a problem with the LRP4 MuSK complex, then the clustering doesn't quite happen. And when the clustering doesn't quite happen, the signaling doesn't go through, and the lack of signaling leads to weakness in MuSK patients. Slightly different clinical progression, and also slightly different biological basis and a clinical basis to the MuSK. Patients with MuSK might have a lot more weakness in their face and throat muscles. They might sometimes have, for example, atrophy of their tongue muscle. It's critical that these patients are recognized early and treated early. The choices are slightly different compared to a lot of the other traditional therapies that we use for AChR positive. For example, in MuSK, there is no complement activation that we know of. So we don't use those complement drugs in MuSK patients. We use other drugs like rituximab or plasma exchange. Rituximab works exceptionally well in most patients with MuSK-MG. The other drug that we commonly use for AChR, pyridostigmine or mestinon, doesn't seem to work as well in MuSK patients. So we talked a little bit about what are the different antibodies, how they cause disease, how the treatments might be different based on it. But I haven't hopefully, that made you feel like, well, let me make sure I know my antibody. At the end of this session, I'll be standing outside taking notes as to what I want. But just make sure, if you're not sure, make sure you know your antibody. But why do you need to know the antibody, right? So the pathophysiology of the disease differs based on your antibody. So in a patient with, for example, AChR, MG, there is complement activation up here, for example. There is also blocking and binding. Whereas in a patient with MuSK, there is sort of prevention of the clustering mechanism. And so there are two different ways that disease is caused based on your antibody. Obviously, a patient for MuSK, we wouldn't be using a complement therapy so much because there isn't as much of a complement activation. Whereas for an AChR positive patient, there is significant complement involvement in the disease. So we actively use that. And other reasons to know the antibody, I'll try to be a little bit more faster. A lot of the newer therapies are approved for AChR positive MG. So for example, all of the complement therapies are only approved for AChR positive MG. Rightly so, because that's the one where we know there is a lot of complement deposition. We don't quite know about LRP4 as much. Certainly no known complement activation in MuSK MG. How about other antibodies? For example, the FC receptor antibodies or FC receptor drugs. Again, a lot of these are still only approved for AChR. They likely do work for MuSK because they, reduce the antibody levels. But in clinical trials, there weren't enough MuSK patients to be definitive. There were few MuSK patients for this drug, the Rosario-Prieto. So this particular drug is approved for both AChR and MuSK MG, whereas the efgartigimod and the subcutaneous form of efgartigimod is only approved for AChR. And so if you don't know the antibodies, it's difficult to sort of advocate for yourself and say, well, I need these therapies, right? And so the other therapies that we frequently use in MG, for example, thymectomy, we think it's mostly effective for AChR positive MG, not necessarily for other forms. So even routinely used treatments like surgery or thymectomy is mostly proven in a particular subtype of patients, not all patients. Whereas in MuSK, the ones that we commonly use are rituximab, very effective, plasma exchange, very effective. I have not personally used it, but this is also FDA-approved Rosario-Prieto. So these are all the different reasons you should know, because how you treat patients, what choice of drugs you choose among the lot of the drugs that are available depends upon what antibody you have. And then the other reason that's important to know is that what is the true incidence of the seronegative MG? This is one of the challenges, and this is where I think as a patient support group or a patient organization, you all can make a huge difference. I just want to point out this one sort of series of papers, and I'll finish up. This comes from the MGFA registry. If you're not part of the MGFA registry, please participate. It's an incredible work that they do. A lot of the interesting publications come from it. As clinicians and researchers, we really rely on that information. So this comes from the MGFA registry, and you can see patients, some of the patients didn't know if they had an antibody or not, but not sure if they're positive or not. I hope after this lecture, these numbers change dramatically. Not just one lecture, but a series of efforts will change dramatically. I'll contrast that with some of the clinic-based registries. So for example, Duke has a very large registry of over 1,000 patients, and you will see about 70 to 80% patients clearly have antibody. We don't quite seem to replicate in MGFA registry. There's also a single center study from Austria where they looked at their patients over a decade, for example. Again, you will see about 85% are antibody positive. I suspect this patient population is very similar, but this is where I think awareness is going to be critical. So as you enter your MGFA registry, as you update things, certainly think about, did I choose my antibody right? Because I think long-term, as we rely on this data to come up with treatments, understand what the requirements are, knowing this makes a big difference. Because when we look at this data, other researchers look at this data, try to get publications through, one of the challenges that comes up is that, well, why is it that your percent positive is so different from in other clinical trials, from single centers, and that becomes a challenge. So, I think Dr. Habib in the afternoon will talk a little bit about seronegative patients and some of the challenges of seronegative patients. I'm not going into that too much. So I'll finish up here. Some of the take-home messages, if you, well, that was all boring. If you want like one snapshot, here is the thing. So antibody, it's part of your immune system, but autoantibodies cause the disease. We all need routine antibodies to fight against infection pathogens. The two common antibodies that you should definitely know about, the AChR and MuSK. There's another one called LRP4. All three antibodies can also be tested by cell-based assay. If you're positive by cell-based assay or positive by regular testing, you're positive. Shouldn't be that different. And what do we do? Why do you need to know the antibody? There are many different reasons. The treatments options currently depend on the antibody. Maybe 10 years ago, it was not the case, but not anymore. Association with thymus gland, and if you need to get a thymectomy or done, again, depend on the antibody. If you have AChR positive, there is data that thymectomy makes a big difference. We need to get a true sense of what is the true incidence of seronegative MG and some of the challenges that the patients with seronegative MG have, and why sort of companies should do more trials in seronegative MG, because some of the data that I showed you are mostly for AChR positive patients. And if you know for sure what your antibody is, there is a great opportunity to participate in different clinical trials, including some of the new seronegative trials. I think I'll stop there. Thank you so much for your attention. I'll take some questions. While folks think of questions, I usually, when I prepare these slides, I always wonder, is it too advanced? Is it too simple? The last time I spoke to some of the patients in Bay Area, they asked me questions that, if they were asked in a scientific forum, there were no answers for those questions. So I don't think I tend to err on being too advanced, but I hope it made sense.
Yeah, that was a wonderful presentation. I was just imagining two things. Has there been any research on patients, MG patients who are on crisis, a correlation between vitamin D3 and MG? Is there any research like that?
Oh, so there were two questions. I'm waiting for your second question. I'll repeat the question. Go ahead. Do you have one more question, or those are the two questions?
One more.
So the questions are, just to make sure we're on the same page and people on the virtual forum. One, has there been any research on MG crisis? And the second question is there any research in terms of relationship between vitamin D and MG? I'll answer the second one. There is some data that low vitamin D can make a lot of autoimmune diseases worse. And this is really well known in other neurological diseases, for example, multiple sclerosis, which is an autoimmune disease that affects brain and spine, where we actively give patients high-dose vitamin D. In MG, we check the vitamin D. If it's low, I replace it. There are very small case series which said in patients where it's low, if you actively replace it, their symptoms improve. But not as robustly. The data is not as robust as in multiple sclerosis.
Okay, my second question is on AI.
Oh, sorry. Let me answer the plasma exchange question that you had. Sorry, 1 second. So there was a question about plasma exchange. So there's a lot of research for myasthenic crisis. The two treatments that we currently use are plasma exchange on an IVIG. Rarely, patients who have a really difficult time in the hospital are not responding. Occasionally, we've used complement therapies in the hospital during a crisis. Whenever some new pharmacy team that said that we want to do a research in MG or we want to develop a new drug in MG, I usually ask, can you think of something for the patients who are hospitalized? Because that subgroup, the treatments have not changed a lot, whereas outpatient things have changed a lot.
Okay, Doc. It's amazing. For the past 10 years, 15 years, there's so much MG has come a long way. Yeah? Yes, so much. So I'm thinking right now, the AI technology is it's been applied almost everywhere. Is there any way, I'm looking forward that AI can apply into MD in the premise of research, technology, diagnosis, or anything like that?
The question is, can AI be applied to MG research, diagnosis, treatment? So I think yes, the answer to that is yes. At least I know of one company that is coming up with new drugs, new ways of approaching therapy based on sort of an AI use model to develop a therapy to treat the disease. That much I know. I think in future, our group is also trying to work with the software side of folks in terms of recognizing when a request comes to our office for a patient, can we incorporate AI methods so that even before a nurse can actually read all the pages to find out what's going on, the system can recognize, oh, this patient has MG, here are the problems, probably should see them tomorrow because they're in a challenging course. So I suspect it'll change, yeah, I expect it to.
Thank you for a very informative talk. Just have a couple questions. The first is, you said earlier that if you test negative for AChR antibody, then you would test for MuSK antibodies. Is there any reason to test for MuSK if you test positive for AChR?
Great question. Just for audience and virtual audience. The question is, we talked about the paradigm of testing. If you are negative, for example, AChR negative, you automatically test for MuSK. Is there a way to test? Is there a reason to test for MuSK if you are AChR positive? Currently, I don't routinely do it. If I'm having a really difficult time with a particular patient, or they're not responding to the usual AChR treatments, I might check it. There are some publications, and I have not been able to replicate it, at least in my practice, where they have described few patients who have both the antibodies. And then the treatment might be slightly different based on that, but I have not come across it.
Wouldn't that just underrepresent the number of patients with MuSK antibodies if you're not testing for it?
Sorry, could you?
It would underrepresent the population with MuSK antibodies if you're not testing for it.
Yeah, so the question is, are we underrepresenting the MuSK patient population if we're not testing for it? I think that's a great question. I don't know the answer to it. Part of the reason is that the only way to do that kind of study is to go back to labs where they routinely test and ask them if they'd be willing to test all their samples that are positive and see what proportions are also end up having MuSK.
Last question is, you didn't mention anything about testing for voltage-gated calcium or potassium channels. Does that fit into this?
So the question is that I didn't talk about voltage-gated calcium and potassium channel antibodies. Just again, to make sure everybody is in the same page, voltage-gated calcium channel antibodies are a different set of antibodies that work against the receptors on the nerve side of that diagram that we always look at when we talk about MG. And they are causative for a different disease called Lambert-Eaton myasthenic syndrome. They have severe weakness. That particular disease sometimes can be associated with cancers, even though it can be completely autoimmune. So I don't routinely test for that in every patient with MuSK that I see. Again, if they're not having the routine clinical phenotype, if there is a history of lung cancer, I test for it.
That's why people test. No.
Yeah. The second question is the voltage-gated potassium channel antibody, which is a different antibody that causes cramping and muscle twitching. Again, if there is a evidence of any cancer or potential for cancer, we do a different test called paraneoplastic antibody where those are captured.
Hi, thank you for being here, Dr. Muppidi. I was one of the people that heard you speak in the Bay Area. Great job again. So I guess my question has more so to do, I'm sort of piggybacking on the question about the testing, but more so for people that are seronegative. What I see a lot of in different patient groups and stuff is that the person will be symptomatic. They have the typical presentation of myasthenia gravis, but unfortunately, they do the AChR testing, all 3 antibodies, nothing comes up. Then they move on to even getting the cell assay, nothing comes up, but they still have the presentation. They do the MuSK, LRP4 even sometimes, the striated muscle, nothing comes up positive. And then the clinician just sort of gives up and says, well, I don't know, maybe this is functional neurologic disorder. There's various other ways to sort of say that, conversion disorder, whatever. And they just leave the person out of gas. And then we see them in our groups. We feel bad for them, but there's nothing we can do. Is there ever a scenario, because you have a lot of hope for a lot of different things to change and to move forward, to where people like that, when they have a presentation like us, but maybe they don't necessarily have MG, I'm not sure. If that person, to distinguish those people, if they are truly seronegative MG, or if maybe perhaps they have like a mitochondrial issue because there was one woman I helped and I kept walking her through it. And in the end, she turned out to have a mitochondrial disease. And later on, it was sad, but a few months later, her 5-year-old son started to develop it. So it was funny, it was all going to come to fruition sooner or later. But is there any scenario where you could see for our people that are looking like us? So they're with us in our groups, they're seronegative, but is there any scenario where they could maybe, like as clinicians, there's a procedure or a process where it's part of like an SOP that then you move on to like genetic testing and mitochondrial testing for those people?
So the question, again, for folks at the back, if you couldn't hear it, is that if you are seronegative, but you're having many of the symptoms, at what point do you say, no, you have a problem, but this is not MG, what do we do? And is there a standard of practice? There is no single standard of practice, but in one of the slides that I had shown, when we go through sequentially, if your single fiber is normal, for example, that doesn't mean that you don't have a disease or you don't have a symptom. It's less likely to be myasthenia. It's a very common challenge because mitochondrial disease, these are mitochondria, sort of the key parts of your cell, help you with energy production, and they're critical for strength and function. And so patients who have a mitochondrial disease can sometimes have double vision, drooping of the eyelids, just like patients in myasthenia might have. So in our practice, we go through that process. If it's negative, then we pursue other things, including mitochondrial disease. Should we get a muscle biopsy for a different variant of myopathy or muscle disease? So we do, yeah.
Okay, my friend was told that she is seronegative, but in the past she has had the symptoms of the musk. So is it possible to be both of those?
So the question is, your friend was told she's seronegative, but she had symptoms of musk in the past. Was the musk antibody positive, ma'am? Or?
Told it was not positive.
So generally, if you were positive at any one point, we call it positive, and you remain positive by diagnosis. Occasionally, it happens that patients are positive at the beginning. They've had many therapies. They get a follow-up test, and the antibody is not detectable. That doesn't mean they became negative.
Sure.
They've always been positive. It's just that the disease is controlled, or the antibody levels are reduced with treatment. If you were never positive, then you would be classified as seronegative. The question about the symptoms, it's not an absolute that if you have a lot of difficulty with swallowing, then you must have a musk. There is no rule of that kind. You could be seronegative and have all of the symptoms, in fact, even be hospitalized with quite a bit of weakness and still be in seronegative. We have many patients like that in our practice. So yeah. It's not a, I want to emphasize this, that this is sometimes lost in translation. There is no sort of suggestion by anybody that if you're seronegative means you don't have the disease. You clearly have the disease. We just don't know the antibody that you have. That's all it means. If you're seropositive, we know the exact antibody and helps us make these choices regarding different treatments that are available. But the seronegative ones, I still believe have an antibody. If this meeting had happened 30 years ago, there was only AChR antibody available. So even the musk, what would have been called seronegative. You see what I mean? So the field moves forward. This is one of the sort of my plug to improve awareness, is that if everybody who's seronegative participates in a trial, or everybody who's seronegative gives a sample, and that gives researchers an opportunity to test, and then we will know more.
Dr. Muppidi, thank you so much. We really, really appreciate the talk. Thank you. And now everyone will go to a short break.
And then one more, I'll get one more water. You think I need to move this over so that the chairs? How are they gonna? Like, all here? No. Awkward.
Before? Yeah, yeah. Ready?
We'll make it work.
I just have it up.
Yes, I will.
I just had a sip of water. I'm good. Just took my medicine. Oh, okay. Oh, no. See, that's why I'm gearing up. You know what happens when you're out. Hey, here we go, the same week through. I wanna- I didn't figure, are you alive? I know.
Yeah, there's gonna be, we have microphones.
There's a.
Are you gonna be able to hold this?
Yes, but then if I need to write down.
Well, we have one.
I'm just supporting you. You're over the table.
You can move it.
Yeah, I got.
I know.
Yeah.
I know.
And, he attends state. I'm warm enough. It's just, you know, I do this when I'm like, I did community theater though. So I might stand up and do a song and dance. You catch it. I might get a Thanksgiving invitation this year if I impress you. Can you start the Rosario?
Good.
I was looking for you all morning. When you sleep in, my friend?
Good, you?
Hi, you made it.
Oh, yeah, absolutely.
Okay, so I just want to talk to you really quick. So,
The only girl. I'm the oldest. I'm the oldest. Okay, you're the oldest. It's nice. So, yeah. So I put on them. So, that.
And then I right?
No, we're gonna get up and do a song and dance. We have to.
Meetings, Kathy.
Oh, you're still working.
Yeah.
You're right, you're right.
Oh,
You don't have to.
it's a curse in disguise.
You don't have to.
Right.
America. I do.
Oh, then?
Average. It's actually. Came to know you something this morning. And then I got to the office, I got, this is what I'll tell you. I just left Amanda's, parking out my. She took forever. She took a pain, pictures of Aurora, she had beautiful pictures. Beautiful. Jenna's daughter. But remind me. She is so cute. Yeah, Liam is definitely tinier than her. So I put I put the video of Liam laughing on my phone for her. She's like trying to crawl in the phone. She's like, I want to play with that baby. I want to play with that baby. So cute.
Yeah, this shot clock is wrong. It's right by. Well, that's. That one, you got 20.
Right. Yeah.
Oh.
They're fun. I'm telling you, we don't know who Dan is, we don't expect it. Yeah.
Oh, thank you. Let's see how long I last.
Very good.
No, not yet. We're still. We're still. That's still. Yeah.
No, I I don't know that I. Oh. My neck man.
I know, right?
I could go one for a walk.
You didn't go in there for us.
That's right. That's right. Never finished. Yeah, not quite, quite. Close as I can get on Amazon. Close as I can get on Amazon. The MGFA, different deal. I know that mess is pen pretty cool. You know, I kind of wanted to sign on that back door just to play it. One.
What? Favorite tree? Yeah. of course.
Don't fall off the stage. The dream team. Sleep well last night.
It's like, okay, yeah.
I know I have to get Amanda, Amanda. Jenny's not, and I said, how many times I can make like a bag of like. And I'm glad I stayed.
Yeah, I had to hey real quick. I was so tired.
Keep doing Q&A. Oh, you're doing Q&A. Word. Yeah, we're gonna ding the bell in a minute. They got started late, so they're gonna give us 10 minutes, 20 of them. Let's keep this happening. I'll give you offer. Yeah, I'll give you offer. Not really good. I know, still a lot of patients about not being. Right. I know, I agree, I mean, I manage, you know. Well, they're new patients. Oh, make me think. Oh, that's good to know. I'm gonna put that in my toolkit.
Okay.
Testing, testing.
You know what? We probably need to grab it. Welcome back, welcome back. Oh. Dr. Briggs, like, at the, yeah, and the neural work, she's here doing that. Well, Kathy, she's on neural. You know her from long hair? Yeah. She worked with me a lot. She worked with me a lot. So when you oh, I got it. Yeah. They did.
Okay, I think we're gonna go ahead and get started. All righty, good morning, everybody. It's nice to see you all, and I hope you've all gotten your coffee and are energized. For those of you that don't know me, my name is Meridith O'Connor, and I am the Assistant Vice President of Patient Engagement, Advocacy, and Policy at the MGFA. I am also an MG patient myself and have been living with the diagnosis for almost 20 years now. So today we are have the pleasure of having both patients and providers for our patient-provider panel. And I know that this particular session, we have done this for many years, but we're going to do things a little bit differently this year. So I hope you enjoy it. So I'm going to look at my notes here to make sure that I get everyone's credentials and everything. So let me do some quick introductions. So here we have Kathy Timothy. Kathy Timothy is an individual living with myasthenia gravis and has established herself as a valued MG community member. Kathy has and continues to serve as the MG support group lead in Tampa, in addition to the Seronegative support group. We at the MGFA also have the privilege of having Kathy as a member of our professional staff, serving as our community outreach coordinator, in which she manages the MG Friends and Support Group program. Next to her, we have Dr. Weiss. Dr. Allan Weiss is a board-certified physician in neurology and electrodiagnostic medicine. He earned his Doctor of Medicine from, I knew I would butcher this, from Hahnemann University in Philadelphia, Pennsylvania. He then completed an internal medicine internship at St. Joe Mercy Hospital in Ann Arbor, Michigan, and a neurology residency at Veterans Affairs Medical Center in LA, California. Dr. Weiss continued his medical education by completing a neuromuscular disease and EMG fellowship at the University of North Carolina, Chapel Hill School of Medicine in Chapel Hill. While Dr. Weiss treats all disorders of the nervous system, his clinical interests include evaluation and treatment of neuromuscular diseases, mainly myasthenia gravis and muscular dystrophy. And then we have Rakesh Nathwani. He is also an individual living with myasthenia gravis. In your program, it says he's actually seronegative, but he is in fact seropositive. So just wanted to make that correction. Rakesh is also a very valued member of the MG community, and we're very fortunate to have him on this panel. And then finally, certainly last but not least, we have Dr. Michael Rosario-Prieto. He's board certified in general adult neurology, electrodiagnostic medicine, and neuromuscular medicine. He earned his Doctor of Medicine from Universidad Autónoma de Guadalajara in Guadalajara, Jalisco, Mexico. How'd I do? I did okay. Dr. Rosario completed a neurology residency at John Dempsey Hospital, Hartford Hospital, University of Connecticut School of Medicine in Farmington, Connecticut. He then completed fellowships in neuromuscular medicine and advanced neuromuscular medicine from Duke University Hospital. He is a member of the American Association of Neuromuscular and Electrodiagnostic Medicine and the American Academy of Neurology. Dr. Rosario attends the MGFA Seronegative support group on a regular basis. So please give a round of applause for our panel today. So the point of today's panel, we really want to hear from both patients and providers. I think we all know we come from different lenses, different perspectives. And I think just having the opportunity to bring everyone together to share their perspectives and where they're coming from and how they approach MG, whether that's managing the MG that they have or treating MG patients that they see. So we'll touch a bit on, journey to diagnosis, how we manage MG, and also focus on quality of life, as that's a really big component. I think in the MG community, it's often something that we don't get to talk about as often as we should. So we'll spend a little bit of time on that. So I'd like to start with Rakesh. Rakesh, tell me a little bit about, or tell us all a little bit about your journey with myasthenia gravis, what it was like, how long it took you to get to an actual diagnosis.
So I can kind of relate my journey to kind of the time around the pandemic. So my official diagnosis was November 1st, 2021. How can I forget that date? Right before the pandemic, I had started experiencing, mostly started with double vision, blurred vision, and being an avid runner, I always paced my mile runs, and I was gradually trying to see that my pace was decreasing. I was losing breath, and that was just before the pandemic. And I was basically getting lightheaded while running. So being that age, I said, I'm just aging, maybe just keep going. And let it go. So that's 2020, 2021. Summer took a toll, being in Florida. And just right after summer, I started getting falls. And the breaking point came in when I had to go drop my daughter at the school bus. And I walk back and I fall. And being an avid runner, you fall and you can't get up. It was, so I finally get up and I said, I think I need help. And what's the next step? So that's kind of where I am. And just to fill in, I'm back running, and I want to get back to the pace I was before. Thank you.
That's great. Thank you so much, Rakesh, and sharing that. I know it's not always easy to share some of our most vulnerable times in our lives. Now, Dr. Weiss, based upon Rakesh's experience, is his experience what you typically see when you are treating or at least seeing someone who may be looking for an MG diagnosis? What does that journey to diagnosis look like for many of the patients that you see?
I think that probably everyone in this room has a different journey, number one. Even though we have this all under the same name. Is it not on? Oops. Is that better now? Can't hear yet. Let's try it. How about now? That's better. Okay, there we go. So I think the first part of the premise is that everyone does have their own individual journey. Some patients get diagnosed right away. Some take quite a while to get diagnosed. Some of it has to do with the constellation of symptoms. I think some of it also has to do with whether the physician thinks about the diagnosis. And then when they do the blood test, I mean, if you're seropositive, the diagnosis usually tends to come a little quicker. For those that are seronegative, then we have to start thinking a little more and have to look at the clinical picture of the patient in the face of those, of the lack of laboratory findings, and make a decision and look at other testing. I mean, I've had patients varied. I mean, in retrospect, patients, have been diagnosed literally almost the same day that they came into the hospital. I've had other patients, in retrospect, probably they may have had symptoms for 40+ years that were that were just ignored, or not ignored, but no one ever explained it. And then they finally hit a breaking point. And then again, in terms of treatment of those individuals, I mean, again, it's going to be individualized to whatever, symptoms you have, what are the medical problems you have, and those types of things.
Yeah, I think you touched on so many points there. And I know personally for me, it took a couple years to get diagnosed. And I know that is not a foreign concept for many individuals living with myasthenia gravis. Now, when people come to you, to your clinic, are they typically coming with the suspicion that they have myasthenia gravis, or that they just have these symptoms and are looking for a diagnosis? Do they have have certain physicians said, well, it could be myasthenia. I'm going to send you to Dr. Weiss or Dr. Rosario? And
it's varied. I mean, some come in without the diagnosis. Some can come in with the suspicion of it, and some, the diagnosis is there, but maybe treatment hasn't been optimal. And so I'm really being asked to optimize the treatment of the patient. All three scenarios certainly we do see, not uncommonly. Again, the seronegatives are the ones that we probably, where they're suspicious of, is say, look, they kind of have symptoms, but the labs doesn't show anything. What do we need to do? And so.
Right, yeah, and I think that becomes so, it's just, I know the journey to diagnosis is incredibly physically draining, emotionally taxing. Dr. Rosario, is that what you typically see in your practice? I mean, people have wait quite a bit of time to get a diagnosis.
Yes.
Do you think there's any merit then to, I guess, how can we get closer to closing that gap, that long time that it takes to get diagnosis? Does that mean educating our primary care physicians? Does that mean administering diagnostic testing earlier on when we start noticing symptoms? Where do you think we can, how can we minimize that gap?
Improving awareness, increasing awareness through community outreach, education to physicians, primary care, ER physicians, improvement in technology with regards to more antibody testing, better equipment, better technology. That's sort of things will reduce that gap.
Yeah, outreach, awareness, education, all incredibly important. I think we've come a very long way from where we were 20 years ago.
Why do you say technology versus like science?
I mean, technology and science, it's more like labs, better labs, more efficient lab, maybe getting optimizing, upgrading equipment so that we get antibody testing. Yes, so these antibody tests will take 2-3 weeks. Maybe in the future we can have it that we can get it the same day. So as technology advances, hopefully that impacts the scientifically the medical community and the MG patients.
That's great. Thank you for clarifying. So let's say we have a patient, they've officially diagnosed with myasthenia gravis. So after a person is diagnosed with MGA, Dr. Rosario, what sort of things other than the antibody status are you considering when you're talking about to this patient about their treatment plan? What sort of things are coming into play when you're helping making those decisions?
Well, for me, the first thing is to make sure that the diagnosis is accurate, getting all the information, getting the antibody testing, the electrical testing, making sure that I have results of the CT scan of the chest. I examine the patient, make sure that I agree with this diagnosis. Not everybody who has elevated acetylcholine has myasthenia. There is this very tiny little percentage of false negative. So I need to agree with this diagnosis. Once we reach this point and we're all clear that this is myasthenia, then first thing I do is I look at the patient in front of me. Is this someone that we can start a discussion about chronic management, or is this someone that needs emergent treatment right away? Is this someone that needs to go to the hospital, get them better quickly? If that's the case, then we work on that, getting you to the hospital, getting emergent treatment. If that is not the case, then I look at the CT scan, for example. This patient has a thymoma or not? And if they have a thymoma, then we start that conversation. Do they need optimization before getting into a thymectomy? If they don't have a thymoma, then I'll probably defer this conversation for later. Then we look at, is this someone's a new diagnosis, or are they already on treatment? Are they already on mestinon? Can this mestinon be, do they have symptoms despite the use of this mestinon? If they do they have side effects from mestinon? Are these side effects something that we can work around, or is it something that we can optimize their mestinon, for example? If I see that that's not a possibility, that we can optimize mestinon because of whatever reason, then we start talking about the other options. Talk about prednisone, but that's where I have to look into the patient's comorbidities. Is this patient diabetic or not? This patient has recurring infections or not? This patient had osteoporosis or not? Prior wounds from poor wound healing or not? And then I have to take all that into consideration before starting a medication like this. Then we make that decision, and then ultimately we decide if that's a treatment or not. And then sometime we need to have the conversation of the next step. And there's a whole, thankfully, there's a whole list of treatment options nowadays, and we discuss them. And ultimately, patients have priorities, patient has preferences. So what's a priority for patient A is not a priority for patient B. Some patients like the fact that they can self-administer something, but they don't like the fact that it's daily. Some patients don't like needles. Some patients appreciate the independence of self-administering a medication, but some other patients prefer to have an IV medicine and not to worry about myasthenia treatment for 2 more months in the case of Ultimax. So everybody is very different. And, so we go through that treatment options. And then I also try to incorporate self-awareness, medications to avoid, et cetera, et cetera.
Yeah, I think you touched on something really important, is that no two patients are alike. And, the thing I think about as a patient and as a social worker by training is I think about all the psychosocial barriers to care, right? And thinking about the cost of medication, thinking about whether or not people have childcare in order to get to and from their treatment centers, things like that. So is that something you're also considering to sort of lifestyle, financial, economic, social factors? Does that play into your decision at all? Because I know from a clinical perspective, what's at stake, but are physicians taking that into account?
Yes, certainly. And certainly that all plays an important role. Patient preference, it's very important, and they base their preference on their job. Are they working? Are they retired? Do they like to travel? Do they not want to be attached to an infusion? Do they want independence? Do they need that? sometimes they prefer something oral, but you need to know that there's a time frame, and oral treatment takes several months to start working.
Right. and
We
really
have that
understand-
time.
Yeah, understanding where they are in their MG journey, like you said, if it's something more of an emergency situation, I mean, obviously that's going to take precedence, but if it's about, management and chronic management, you can have those discussions and those conversations, and decisions can be a little bit more fluid. Now, Kathy, I want to go to you. So when you were diagnosed with MG, as a patient, what sort of things were you considering when you were discussing your treatment with your physician? And I guess in addition to that, how have your goals evolved as you've now been living with the disease for quite some time?
So at first, I had never heard of myasthenia gravis. I had worked in healthcare for over 30 years, but the business end of healthcare. But still, I had a lot of disease codes pass over my desk, had never heard of it. And my daughter, who was a nurse, had barely heard of it. So when it was, go home and take this pill, I didn't even know what to ask at that point. And I thought, oh, I'll just go home and take this little pill 3 times a day and I'll keep working, because I had worked through chemotherapy 25 years prior. And it wasn't 2 months later that I experienced my first crisis and didn't go back to work until recently. And that was really difficult. And then I realized that I had to educate myself to be able to have educated conversations with my provider. If I didn't know what was out there, if I didn't know what was available, if I didn't know how the different meds worked, like we talked about this, the socioeconomic, what would fit into my schedule at the time? Could I get to treatment? Then how could I have that conversation with the doctor with any meaning? I could blame my doctor for my poor quality of life if I wasn't doing my own self-advocacy. And I don't mean going in and saying, oh, I read about such and such in a book and can you prescribe it for me? But to have that meaningful conversation. And my goals changed. So at first my goal was, I just want to go back to work. I just want to go back to work. That's all I was focused on. I had just gotten my master's degree later in life and was very proud of it. Had just gotten a great promotion at work. And all of a sudden I was cut off at the knees and I just wanted to go back to work until my daughter reminded me that I had a lot more purpose in my life than just work. So then it was, I want to be able to be here when my grandchildren graduate from high school. I want to be able to play with my grandchildren. And then there's the famous story out there to my family. I want to be able to pick out my own peaches. I want to go to the produce stand. I want to smell them. I want to touch them. I just want to be part of the peach experience. And so where I went from I want to work, I became, it's so simple. I just want to be part of the peach experience.
I love that analogy. I think let's start using that. But it speaks to the fact that everyone has their own goals. And I think that, your goals might not be the same as my goals. And we've talked about this actually, discussing, our various treatments and, where I am in my stage in my life and having to consider that if I want to start a family later on, thinking about how those, treatment considerations, what needs to be factored into that when having that conversation with my doctor. So but you speak to something about the peaches. I love it. Which you're kind of getting into this concept of quality of life, right? Like getting back to quote unquote your normal. And I think that a lot of us MG patients often feel like our quality of life is tremendously impacted by our MG diagnosis. And I think part of that is that we often feel like a burden to those that care for us, love us, support us. Now, in terms of quality of life and, making sure that patients are advocating for themselves, and this is really to all of you, I guess, what would be some tips and suggestions that we could offer those who are either newly diagnosed or just having a conversation with their doctor that they've had a relationship with for 20 years? What can we advise them on how to really communicate those goals, communicate those specific desires, how to really facilitate and make the most of that conversation that you're having with your provider, because it's a very short time that you are in the doctor's office. I mean, we all know how it goes. So do you have any tips, Kathy, for individuals who are maybe just don't even know how to even begin to have that conversation with their doctor?
I think going in with a targeted conversation, getting your head wrapped around what you want to talk about prior to your visit, because we know they only have so much time with us. So if we go in and we're kind of trying to do it on a whim, we may forget something very important. There's actually a great webinar posted on the MGFA website about how to prepare for your doctor visit that I'd encourage you to watch, to take your notes, to go in with a one-page summary. This is what I want to address. And of course, sometimes your doctor may have another issue if your lab work is way off or if you've recently had an exacerbation. But again, our definition of quality of life may be very different than our provider's definition of quality of life. Our definition of quality of life is very different than our loved one's definition of quality of life. And just being able to find a way to communicate that. And I'll give you an example. My sister just came for a visit. I get so stressed out when she comes. She's a good person. I love her, my best friend, but she feels the need to rearrange my kitchen. And it's like, it's not aesthetics for me. It's accessibility. So yes, my toaster does need to be on my counter. And no, my coffee pot can't be all the way in the back. And yes, my mugs do have to be down here. But how, as somebody living with MG, do you explain that to somebody else who thinks, well, you can get the toaster out of your bottom cabinet every morning? No, I can't. That just takes up too much energy for something else I want to spend it on. So finding just your voice and a way to compassionately communicate. And when you find the way to tell my sister that, I will give you her email address.
Well said, well said.
If I can chime in,
Please.
well, as a patient, I've been hearing this quality of life, there's a term quality of service when we talked about, internet or whatever it is. So I like the term quality of life, QOL. Just like we have the MG-ADL scale, I think with the amount of treatments we have, the amount of, research and the drugs coming in the pipeline, I believe we should have a QOL scale, and every day we measure how is our QOL scale, how close are we to what we think is our normal. For Kathy, it was, getting the peaches from the nearest, the farm stand. For me, I want to get to my 7.5 minute mile, and I would measure my quality of life based on that. So I think I started my MG journey. Those who were here yesterday, if you remember, on the slide there was that tree with the prednisone patient, and I pretty much hit every branch coming down when I weaned off prednisone. And maybe, after those newer drugs, the drug I am on got approved December 2021, and it's helped me a lot. And when I go see my neurologist, I kind of gauge, hey, where am I close to my quality of life, and how can we tweak our dosages so I can achieve that. So I think the expectation I want all patients here, or even the caregivers, is it's not that we just need to live with it. How can we be close to our, the quality of life we want in our life? I think this disease has come to that stage. While hopefully there is a cure down the pipeline, but at least our generation, that should be the the marker, I think. And I think everybody here should go away after the end of this conference with that expectation. I hope so. Thanks.
That's great. Thank you. Yeah, Dr. Weiss, go ahead.
I would just, add, this is working again. Again, we have to remember this, while this disease affects an individual, it affects everyone around you. It affects your family, it affects your work, it affects every aspect of you. And I think sometimes we kind of underestimate how much an impact, which is some of the quality of life that you talk about, can I still provide the same quality of, of work that I did before? Can I even work again? Can I work again? Can my family members, whether it's my spouse, significant other, children, parents, whatever, being able to interact with them the way I want to? And I think that's something that we don't really measure very well. But I think that's a really important aspect of the disease, which is why I think it's important. I know a lot of you here, not just patients, but also caregivers, family members, because it really involves not just the patient, but everyone. And so the more, and frankly, knowledge is the best you can do, and understand what you can do, what you can't do, what you should or shouldn't do, or avoid this, but you could go ahead and do this. All those things, and have the support of your family is really important. Unfortunately, over the years, I've had a few patients where their families were not quite as supportive, and you're lazy. Why can't you do this? Why can't you do that? It's unfortunate, and you can educate the best you can, but everyone's different, shall we say.
Yeah, I think speaking of support systems, I think talk to me a little bit about the importance of having a support system. We shouldn't underestimate the power of having support, especially in myasthenia gravis. And I think, for me personally, having a support system in my life who has been with me every single day over the last 20 years. I mean, my mom has gone with me to almost every single neurology appointment to this day. So it really is a family disease. And I would say I wouldn't be here today, where I am today, how well I'm doing today, if it wasn't for my care providers, my loved ones, all the people that are there to support me. How critical is it? Have you seen a difference, at least in your clinic, whether Dr. Rosario and Dr. Weiss, people who don't have a support system, and how that affects their overall well-being?
Yes, clearly it does. I can tell you about a patient that I have who family wants to not be very supportive and want to kind of dictate what mom gets and does not get. And that has caused a lot of trouble for this patient. So it's important that family is involved, and we're a team, and we're trying to help, and we all work together.
Any last comments? Because I think we're going to open it up to the audience and take any other questions. Kathy or Antwani, did you want to share it?
Meredith, can I just, and I've said this in my support group so much, is that for the caregivers in the room, I have the utmost respect for you. You still live with the disease. You live with the uncertainty, you live with the fear, you live with the having to change plans at the last minute. You live with, okay, my daughter's a nurse and I was in healthcare, so we have a little sick sense of humor. But at 8:30 every morning, she calls me. And if I don't answer that phone at 8:30, she calls me incessantly. She can't start her day because she's afraid I'm on the floor or worse. So you all live with it every day. You just don't have the physical symptoms that we're experiencing. So please don't ever discount your suffering from this disease also, because I commend you for what you do without knowing exactly what we've really difficult for you. So I just wanted to take a minute to say how much I appreciate what your caregivers do.
Yeah,
Can I add something
please.
with regards to the quality of life?
Yes.
Looking at it as a provider's or physician's lens, it's not embedded in our DNA. It's not taught. When you go and see the doctor, you get examination. We're measuring your strength. That's what we get. That's what we get taught. So there's a dichotomy between what is in my list of importance things and what is in your list. For me, let's say, for example, you're on IVIG, and this is just an example. Well, I want to make sure that it's not causing anemia. I want to make sure your kidney function is normal. That's in my list of priorities. Your list of priorities is I can't finish my laundry load, or I have to split my yard work in 2 days. So what I'm here to do is very different what you are here to discuss. And that's where meetings like this unites. That's where support groups are very helpful. It has helped me a lot, understanding patients' need. I would like for everybody to go online and print that MGADL form. I have incorporated this into my practice over the past 2 or 3 years. And I look at this as soon as I go into a room, first thing I see is I look at the MGADL scale. That's a scale that was designed for you as a patient. Let the doctor know how's your quality of life, how's your activities of daily living. And I take this into consideration when I'm on, that's not the only thing we use. We use the exam, et cetera, et cetera. But when I'm on the fence, if patient needs optimization or not, that's something we look into, and everything together help us help you better.
Thank you. Another thing that crossed my mind as you were speaking was thinking about the treatment landscape and where we are today. Obviously, we've come so far, from just having pyridostigmine to now having multiple treatments. I guess talk to me a little bit about approaching that conversation when, discussing treatment options and sort of what that looks like. Because I think right now we're in it's like a good problem to have options, right? But it's almost overwhelming because, we're learning so much new information about MG. I know for me as a patient, it's overwhelming. As an advocate, it's overwhelming. So how do you have those conversations when exploring treatment options and even clinical trials, making sure that people are aware that clinical trials is an option as a treatment strategy? What does that conversation look like when you're talking to MG patients and their families? Please feel free.
So as it's precisely that, is a discussion, is an education session. It's unfortunately, there's not a lot of time provided for that in a regular office, but we try to do our best. But it is precisely a discussion, and there's many alternatives. They all have good and bads. We look at the patient's comorbidities. Insurance have a lot to do with what we can choose. But, we present data, we present how is it administered, is it oral, sub-Q, IV, the frequency, side effect profile. And ultimately, the patient will be educated enough where we can all make a decision together. But it is a conversation rather than an imposition.
I think that's at least the problem that I see is it's a great to have that conversation, but there's so many things that inhibit people from getting access to the care that they need. And, it's part of the healthcare system in which we live in. But I wanted to open it up to the floor, see if anyone had any questions for either patients or providers here on this panel. Anything related to MG. I don't know where are our audience Q&A people? Okay, great, thank you. Sorry, go ahead, and I can repeat the question. So just to repeat the question was, when you encounter an experienced patient or an MG patient that has had MG for quite some time and they switch neurologists, what is that relationship like, and what's that conversation look like? Perhaps that they've been through multiple treatments. Do you find them to be difficult patients because they kind of feel like they're the experts, which in a way they absolutely are? What is your approach when talking to experienced or MG patients that have been living with MG for quite some time?
I mean, we're in Florida. We have lots of people that come from someplace else. So a lot of them move down here with time. And so we're used to having patients who came from someplace else with a diagnosis, 5 years, 10, 20, 30, 40 years. Do I think it's any more difficult? I don't think so. I think that what you want to first do is I have to make sure that the diagnosis was correct. I mean, it doesn't mean I have to do every part of the workup, but at least have some reasonable thought that, yeah, this is what the patient has. And then you look to see, depending on how they're doing. If they're doing really well, you know, if it ain't broke, don't fix it. But if they're still having symptoms, you know, we have a lot of choices, and some you may not have had 10 or 15 years ago, because a lot of the newer medications weren't available. And say, well, you've done this, we've done this, you've kind of maximized these 2 or 3 drugs. Okay, given the circumstances, this may be your best drug to go forward to maybe improve you even more so. But I don't find it, again, the challenge actually is just getting the records from the previous neurologist to at least see, especially, you know, if they were seropositive, unfortunately, the insurance companies want you to demonstrate, they want to see the lab, not just something you've dictated in your note. So it's more of logistical challenges, but I would say, you know, a very high percentage of the patients I've seen who've been diagnosed a long time ago, they probably did have myasthenia. Now, some have, when they've come in, they've presented with actually symptoms that may not have been myasthenia. They thought may have been part of it, may have been due to a different entity. That doesn't dissuade me from, you can have more than one thing going on. And so we have to look and say, okay, well, now their legs are mostly their big issue when it should be more your arms. Okay, there may be something else going on separate from it, and trying to distinguish that. Again, I think you take each patient individually, because again, as I mentioned earlier, everyone has their own journey. And no 2 patients are exactly alike. So you have to look at that journey that they've had already and incorporate our best thoughts into what will be the best way to optimize the patient.
It's a great question, because I think, I know I've actually had a conversation with a fellow MG community member, and he and I were talking about, you know, changing treatments and, you know, what that would look like. And I know for me, I am very conservative when, you know, trying to determine if I'm going to change a treatment or not. I really don't like to, for lack of a better word, rock the boat, because I think sometimes the risk is just far too significant in my mind, with no guarantee. But this fellow MG community member was like, yeah, I'll try it. I'll try anything to make me feel better, you know? So I think, like you said, it really varies from patient to patient, and really meeting people where they're at. So great question. Thank you.
Hi, thank you. Dr. Rosario mentioned a character in this story that hasn't come up much, who has dominated my experience. We've talked about choice, but I have none. United Healthcare chooses my medication, not me, not my doctor, right? And is that I'm wondering, is my experience unique because we're not talking about insurance often here? And we kind of seem to be pretending it's not a big problem, or not pretending, but we're not calling out as a big problem. So is my experience unique, or is getting an insurance company to recognize the advances in treatment, and is that a front we should be fighting on, because I'd like to go fight them?
I know I'll speak as an advocate, as an MG patient, that no, your experience is not unique, and I think you already knew the answer to that question, but it's a great point to bring up, because I think our healthcare industry, our healthcare system is really complex and multifaceted, and that's sort of what I was alluding to, as in terms of getting access to the treatments, is that, you know, we could say XYZ is the perfect recipe to treat MG, yet it takes, you know, you to try this A, B, and C before you can even try X, Y, Z. And even that, you're not guaranteed. So and I think it was brought up yesterday at Dr. Vu's keynote is, what are physicians doing as to advocate on patients' behalf when we are constantly faced with having to battle the insurance companies to get the medication we are prescribed and that we deserve and need?
I mean, dealing with insurance, I mean, most of that's going to be at the national level, unfortunately, in terms of to have six broad changes. As a physician, I mean, I know of many physicians that won't even talk to a medical director, for example. Oh, it's too bad, we're done. Part is we're the advocate for our patients. So I mean, unfortunately, every case you got that's an issue, you have to then go talk to a medical director or find whatever it is in order to be able to get the treatments we need. I mean, the problem is that, and unfortunately I've seen this, is that there are neurologists who may not be as expert in myasthenia who are ordering medications for patients without really going through a stepwise logical approach. They want to go, oh, this is the newest drug, we're going to go straight to that. Maybe not fully understanding the implications of that. And so as a result, this pushback from insurance companies saying, well, we're going to just carte blanche, unless you do X, Y, and Z, we're not going to allow you to. You have to try this drug and this drug and this drug beforehand, unfortunately.
Right, and that's the reality we face.
Yeah.
I mean,
Unfortunately,
I think everyone thinks it's a great system.
Unfortunately, as the patient continues to do worse until they get the medication that you really need. I've had plenty of arguments. Oh, don't worry, I've had plenty of, we'll call them discussions with medical directors over the years. And, basically they're just, well, this is our policy.
Right. So yeah, advocating at a legislative policy level.
I mean, up until recently, you never needed to have any kind of like an MG-ADL score in order to get approved for a medication. Now it's, yeah, we want this, we want this, we want this, and it's just more roadblocks and makes it, and the thing is, it's already stressful enough for our patients. It's just another layer of stress that's added. Am I actually going to get this treatment, or am I going to have to try something else that may or might not be good for me, or am I just going to have to suffer until I get bad enough where then they'll have no choice but to allow me? And that's part of the challenge we have. But it's hard to across the board be able to do that's way beyond what we are at the local level, unfortunately.
I can chime in.
Please.
I mean, I totally empathize. I was fortunate, I was seropositive, and even getting approval as a seropositive was a challenge, right? All these newer drugs, the costs, there's every incentive for the medical industry to decline treatment. I can relate an example. The treatment I am right now, it was rejected. And the simple reason I was given was it's not in our formulary. And I left it there, tried 6 months later. I tried 6 months later, and it just got approved. And so these newer drugs, yes, it'll be a challenge getting approved, but I think all of us have to try our best to push the button and say, this is what keeps me going every day. And the cost alternative is going to be worse. And I have actually had an example. I had a fall, and the cost of the fall was actually more than what they were paying for my treatment. So my case became even easier when my doctor was able to prove that the treatment was actually a better option. So don't give up. These newer drugs will take some time before it's widely accepted, but I think we all have to give it a try and just keep trying every day. Thank you.
I mean, some of the challenge, again, as you pointed out, is that they're more worried about the cost of the drug there, but we've had patients who've been on medications longer than we would have liked to, people who've been on prednisone because we couldn't get to the next step, who basically, and they start having complications from that. I mean, they're frankly, unfortunately, worrying about their bottom line, but actually in some patients, it's actually cost them a lot more if they had just give us the medication from the beginning. you know, again, your body still takes a toll. I mean, it sounds crazy. I mean, we've had prior authorization requests for Mestinon and prednisone, which I guarantee that authorization, especially prednisone, the cost of what it would cost for a year's worth of prednisone was more than what it costed an insurance company for what they had to pay their personnel to do all the paper pushing. So, you know, it's just, you know, it's unfortunately, it's beyond our control, and unfortunately, every insurance company is different. But you have to fight the battles for you. I mean, as physicians, that's part of our job, is to help fight that battle for you as best we can.
Thank you for the question.
Questions at the beginning.
Yeah, we have time.
I have a comment more than a question. So I'm a veterinarian. So this is the first time I've gotten to hear human medicine say quality of life, quality of life, quality of life. I know I said it to my first neurologist and she kind of just dismissed it. And now I see Dr. Rosario, and that was a huge discussion that we had. And we have it in veterinary medicine every day. And it mattered because I think I come from that side so much to me when my quality of life declined because of this diagnosis and this disease. And I just want to say it's so nice to hear people say that our quality of life, it matters. I mean, if it matters for an animal, no offense, it really should. It should matter for us as human beings. And also I'm really glad veterinarians don't have to deal with insurance. It's so much easier.
Thank you for that comment. I think you speak for many people. I know, at least I can speak for myself, but also for the people that I speak with on a daily basis with myasthenia, is that sometimes the mental and emotional impact this disease can have is sometimes worse than the physical symptoms at times. And having to cope with that and manage that, I mean, it is a full-time job, and really trying to communicate that to people who are able-bodied or not in the MG community, I think is a whole nother job in itself, right? And really trying to convey that every decision we make, I always say every decision I make is incredibly calculated, has to be very well thought out in order to preserve and conserve my energy, the little energy that I have. So absolutely. And I think having that validation from the physician's perspective too, is that they are taking this into account in that quality of life, whether that be from deciding what, the administration of a certain treatment to the side effects. They're very much thinking about these things. And it's something to be valued, and something that I think if they're not, it's having that conversation with your doctor and learning to better advocate for yourself. You have to advocate for yourself. So thank you for the comment. Any other questions?
Animals can get MG also. Have you seen any animals?
I've seen one.
Okay.
Your practice, but it's the running joke when I tell colleagues, they're like, oh, what do you have? And they're like, they just make the joke of, oh, it's super rare. And they're like, myasthenia. And I'm like, I am the running joke among my colleagues because like, it's so rare, but more vets have heard of myasthenia gravis than I feel like physicians have, honestly. And I did see one in my first year of practice. It had a thymoma and it was really old.
Oh my gosh.
How do they treat animals? Like, do they most of the time it's like
We could table that conversation, but the question was about animals living with MG. And we have a veterinarian in the audience, so she was commenting on that. Oh, I'm sorry. What was the answer? They couldn't hear it. Do you mind giving her the mic? Thank you.
The answer is yes, animals can get it. And we actually learn more about it, I think, in vet school than MDs do. And I have seen one case when I first graduated, pre me having myasthenia, but it's not really treated much in animals because we diagnose it often secondary to like a thymic cancer or something like that. So it's a different process than a lot of humans have.
Any other questions? Back there.
I had a cosmetic surgeon because my ophthalmologist wouldn't, he didn't think there was anything wrong with my eyes. So I thought, well, I'd go to a cosmetic surgeon and get them surgically fixed. She said, I think you have more of an issue than that. So she sent me to an eye specialist, a neuromuscular ophthalmologist. He said, he did all the testing. He said, you have MG. I didn't know what that was. He told me to get in a support group. Well, every doctor I went to told me I had functional neurological disorder, with much thanks to Jessica sitting up front and Kathy Timothy on a support group telling me, you have to advocate for yourself. You have to do this, you know. Go see Dr. Weiss. I live in southwestern Pennsylvania, but I came down to see Dr. Weiss, and he saved my life. I cannot find a doctor in Pennsylvania that knows what myasthenia gravis or the treatment. They won't say, you know, I have it. So I found a doctor 2.5 hours away in Winchester, Virginia, who was helping me. Said all that to say that, ask this, what can we do to make doctors listen to us and believe us? You know, we don't want this disease. God, that'd be the last thing I'd want. What can we do to make them believe us? And what are they doing to learn more about it?
Thank you for sharing your experience. I think you're not alone in what you have experienced. I know for many of us, we have been called crazy. It's all in our head. We're making it up. We're being lazy. I hear that a lot, and I was experienced that myself. So I'm going to hand that question over to the physicians. You know what? How do we do better for this community? Because I think more often than not, patients are faced with like, well, it could be, you know, maybe you're just tired, or maybe you're just anxious or depressed, or, you know, how do we do better for this community? At least from a physician's perspective, how do we be what is it that you need for us to be our best advocates in order to ensure that we're getting the quality care that we need?
I don't know how to answer that. You know, it's education in our behalf as neurologists. Neuromuscular diseases are rare. Myasthenia gravis is a section of neuromuscular diseases, and neuromuscular diseases is a section of neurology. So even myasthenia gravis is not even well known by neuromuscular physicians. Some neuromuscular physicians focus on nerve disorders or muscle disorders or ALS, etc. So it's just very hard. We have something that now that wasn't present 20, 30 years ago, and that's the internet. You know, the MGFA website had a list of physicians who treat myasthenia. That's a good first place to go. Go to MGFA website and see the list of physicians that are trained and to recognize and treat these diseases. So utilizing those resources, and you are your best advocate. Keep going at it, keep complaining, keep going at it, and don't give up, and use the resources that the MGFA provide. And that's actually a good advice. Go to MGFA website, see who close to you treats myasthenia, and that's a good place to start.
Other comment I would make, unfortunately, people who they refer to as MG experts, it's not spread out equally throughout the country, which is a big issue. You know, you go along the eastern seaboard, there's a whole bunch of people. As you start moving farther west, other than a few pockets here and there are less and less, and there are states where there's almost nobody that does myasthenia. So that makes it a challenge, because that means you're having to, that forces them then to travel, several hours or get on a plane in order to be taken care of. That adds to the issues. I mean, again, most on the Eastern Seaboard, you can pretty much find someone probably within a couple hour or two at worst. But again, especially when you get out to the West, there's almost no one, other than California, there's not a lot of people. There's some, but not as many. And so that makes it very difficult because again, the myasthenia patient that has a fair number of symptoms really do need someone with that kind of expertise. The general neurologist is not going to be able to take care of that adequately enough. It's not their fault. That's why we do fellowships. Even again, and as Dr. Rosario said, even those that do neuromuscular fellowships, you get more or less exposure to myasthenia. We both were places where myasthenia was pretty, between Duke and UNC, there's quite a bit of, quite a few patients and a great amount of exposure, but not everyone has that luxury.
Okay, I think we are at time. Thank you to each and every one of you. Thank you to our panel. Let's give a round of applause. Oh, and then I believe Sam wanted to come up here just to.
Nope, I can make a quick announcement
Oh,
right here.
She's gonna make a
First-
over there.
This one's really, really important. Lunch is out past registration again, where we ate last night. So there's tables set up. You're of course welcome to bring your lunch back in here. I've lost track of the time, but we're going to try to reconvene at 12:45 so we can get back on schedule for you guys. And then also, I just wanted to share, and tomorrow morning, we're going to talk to you more about ambassadors for the organization. But we have Michael Lifshitz here. Hi, stand up. Michael Lifshitz was a longtime board member for MGFA. He's been supporting the organization for decades. He attends all of our community health fairs and other events, and he helps people understand how they can become more engaged and involved with the organization. A couple of us as staff have been approached by several of you about how you can become more involved. And I welcome you to keep coming up to the staff, but also Michael is here. So have a conversation. That's it. Okay, thank you. Enjoy lunch.
Thanks, everyone. Hey, how are you? So nice to see you. I know, right? Isn't it so nice to be together? You have such a lovely stage. You have such a human sensitivity. Yeah. It was something for you because we're spending all the time. We're grateful to have this. I know. I try my best to compare the